So the first element that distinguishes the alternative quality contract from our traditional contracts is that it's designed for an organization that's willing to take accountability for care across the entire continuum, from birth to death and everything in between. Now, importantly, and consistent with some of what we've heard the rest of the morning and the early part of this afternoon, we haven't been prescriptive about what that entity needs to look like, only to say that it has to have at its core primary care, and that's because the whole model and the budgets for the model emanate from the patients who are attached to primary care physicians in the AQC organization. The second piece that's distinct is this is a long contract. You can see in the picture it's 5 years. Our typical contracts with hospitals are 3 years. Our contracts with physician groups can be, or individual physicians, can be anywhere from 1 to 3 years. So a 5-year contract is a long period of time, and the intention there was to be successful under this model is going to require really providing care very differently, and we didn't want either the organization or ourselves to be distracted by another contract negotiation that's just around the corner in 6 months or 12 months. So a 5-year contract. A third feature about the model that's distinctive is that the rate of inflation year over year is negotiated upfront and is tied to general inflation. So that's the yellow piece that you see there, which is not getting larger every year. That yellow is illustrating how inflation accumulates over time. And so the amount that's accumulated by year 5 is the amount you see there, much, much lower than the double-digit rates we were talking about on the previous slide. A fourth and very important distinctive feature about the AQC model is that it moves off of fee-for-service as a basis for payment and onto a global budget. That global budget is what's represented by the dotted line that goes across the middle of the page. Unlike some previous runs in the 1990s about setting global budgets or capitated sums, the way this budget is set is based on that organization's historical rate of spending. So back to what I was saying at the beginning, not trying to take money out of the system, trying to take the current rate of spending and get it used more effectively to produce better quality and outcomes and slow the rate of growth in spending. That global budget is set at that organization's existing rate of spending for the population it takes care of. And then what gets managed is how quickly that budget goes up year over year. It's important to notice that the way the model was designed, the dark blue that's below the line there, in this picture that's a hypothetical. It could be any amount, but what it's meant to illustrate there is that if that AQC organization identifies waste in the system of whatever form, that the savings extracted by addressing that waste actually are retained by the AQC organization. And we hope used to reinvest in improving care. Now, the fifth and final piece that's distinct from our traditional contracts is what's pictured by the green, and that is a pay-for-performance component, but an extremely robust one. I'll describe it in more detail in a moment, but that's a pay-for-performance component that gives the potential for up to an additional 10% earnings on the global budget. What I can tell you about what we've called lovingly the class of 2009 AQC organizations, that is the organizations that include these two, but include several others that came in for a 5-year deal starting in 2009, is all of them started somewhere already above gate 1. But what is really, truly remarkable, it has been the rate of improvement that these organizations have made across that broad spectrum of measures has been both significantly faster than their historical rate of improvement on those measures and significantly faster than the rest of our network. And so I would attribute that to a few things. It's not just the incentives. It's the leadership in these organizations to act on those incentives. And it's also the ongoing data and support going on between our two organizations. So no longer is there kind of a pay-for-performance model where, you know, at the end of the year you get a report and a check that tells you how you did. This is an ongoing flow of information, sometimes bidirectional, some of it actually on a daily basis, but much of it monthly or quarterly, to help inform these organizations' success on this part of the model, as well as on the below-the-line savings.
At one of the meetings that I was at where Judy was chairing, one of the people from the Mass Hospital Association said ACOs are like unicorns. Everyone thinks they know what one looks like, but no one's ever seen one. And I think there is a reality there. There's also a lot of opportunity, because we can begin to describe for ourselves what we think this ACO thing is. I think it's a concept in evolution as well, and I think the work from Vermont demonstrates that you can get there in a variety of different ways. If you actually go back to Crossing the Quality Chasm in 2001 and look at the 10 or so descriptors of what they considered to be a high-performing organization, they were envisioning what's happening now. There's a very interesting paragraph that lies right before that, and it says, it's our impression that you can get to this in a variety of ways. And in different places, you should do it in different ways. And I think that it is quite prescient that they were able to realize that now almost 10 years ago, and that over the course of the last 10 years, we've been living out that reality. One of the first things we did was to try to create a patient-centered care model that took all of our patients with the use of our data warehouses and tried to segment it into 4 groups. One we called green, those were basically people who were healthy. The next group was yellow, those were people who had 1 or 2 identified medical problems. The third group was red, which was people who were in and out of the hospital a lot. And the last group was blue, which were people who had end-of-life issues. And we were trying at that time to think about how we would be taking care of people in each of those populations differently. That work, I think, was foundational. We have moved on from what we learned there. What we basically learned was you can't have a bunch of people sit in a room in a central office and figure this out and then have anybody else accept it. That it actually had to come from the group itself in a different sort of way. Because, in fact, the changes that we wanted to implement in our organization after we had created this plan were resisted by our practice. I think, back to the basics, the thing that's working most is when we convene people and have them work together, much as Mark described earlier this morning, the QI councils, the regular site visits, all the conversations, the move to team-based medicine. You know, that's not a choice, that's a reality. By 2020, there will be 90,000 fewer physicians than there are now. And most of those will be in primary care. SG2 estimates that there will be 1 primary care physician for every 10,000 adults. That's 10 years from now. Where are we going? Well, I've just described it, I think, in the course of the talk. We're really headed on an adventurous trip. We know that there will be many challenges along the way, but we sort of know that the things that we've begun will probably add value. We're constantly looking for new things that will be new assets and new ways to create value for our patients and for our community. I actually think the next big step is a very, very high-level collaboration between the various groups and institutions, and I guess almost like warring camps that exist within our state, very much like in Vermont, towards something that's based in the desire to improve the health of the community.
One of the challenges for people who are just starting out, I think, is that it's a tremendous culture change for physicians and for administrators to change the way they practice. To take an office and change it to the medical home model, to have physicians suddenly have to listen to a pharmacist tell them how to deliver and what drugs to use, to have a case manager or a care manager tell them where their patient can go and whether they're ready for an acute rehab or a chronic facility, is a whole different mindset for physicians. Physicians nowhere in medical school, and I think anybody who has kids in medical school today will tell you this, do people learn how to work in a team? Physicians are taught how to take care of the person right in front of them, and that's what they care about. There is nothing in medical school that teaches them how to work in a team or how to do population medicine. And what we in the world in the future is asking them to do is change that framework. We are asking patients to accept that it isn't just the doctor anymore who's going to give them care. In my office, it's my medical assistant, my physician's assistant, my care manager from the IPA. It's a whole team of people. It's the nurse practitioner who sees people in the home or sees them in the nursing home who work with me, who are delivering the care. I'm the end of the line. I'm the last person to see them when they're really, all the other people are failing and they're not doing well. I don't call them to tell them that their hemoglobin A1C is high and I want their med to change. I may be the one directing that, but there's a diabetic educator and a nurse and a whole bunch of people. So getting the patient to understand the care is being given in a team and for them to feel good about that is a challenge that we have to face because patients still think it all has to be done by the doc. Lastly, getting to yes on a contract with a payer and the hospital and the physicians is very, very difficult. It requires a lot of trust between the payer and the providers. It requires trust between the PCPs and the specialists, between the hospital and the docs. And to get to a contract that people can agree to in an ACO world, I think is going to be much more complicated than in a fee-for-service world. There are things that we haven't heard about today. So if you're going to develop an ACO model, you have to develop an infrastructure to do that. Well, the payments in the ACO world come only after you've been doing it and been successful and reached certain criteria. It's enormously expensive to put together a medical home model. For a private practice of 4 docs, I would say without getting some capital up front, it's virtually impossible for them to get NCQA accredited as a medical home. For an IPA to put in the infrastructure that we have without years of investment from surplus is impossible. So basically, I think we are a model of success because we focus on all the things that people have talked about here today. We focus on education, consensus, we try to involve our patients in their care, but we've also been lucky and fortunate that we've had the success that we can build on our success. And as people start out, it's going to be a much harder world, I think, than where certainly Atrius and we are.